When people start, one of the great things we've got is trending data. It's not possible for your trainer to be in the consultation with you all the time. And we've looked now across 13,000 consultations. We find that when people start to consult earlier in their journey, you see things like they talk a lot more. The doctor talk time is a lot more than the patient talk time. And as they practice and get feedback from their trainer and become more experienced in consulting, you see that doctor talk time coming down. Training is hard. It's a busy time of life. Often people have young families or other things going on, and medicine has become increasingly complex. So I think it's hard work being a GP resident doctor. So I really think you need a good, strong bond, and I don't think a computer is going to provide that. People don't care what you think until they know that you care.
AI is changing how GP residents learn consultation and revise for the MRCGP SCA. But can AI genuinely help a GP resident become better at consulting? What are the risks of using AI? Hi, my name is Dr Erwin Kwun. I've helped hundreds of GP trainers plus SEO with confidence. Today I'm joined by Nicholas Book, a GP with an interest in medical education technology. We're going to look at what are the common mistakes GP trainees make when they're using AI, how to use AI well, and more importantly, how you can pass your SCA exam. Let's dive right into it. Hi Nick, how are you doing?
Yeah, I'm doing good. It's nice to be here. Thank you for having me.
For people who might not know about you, share with us your journey from how this interest in medical education started.
So I'm a Birmingham graduate, and I started off probably there with an interest in wanting to teach my fellow medical students. I always enjoyed that. I felt it was a way that it helped me to learn as well. So I started off doing a bit of teaching at medical school, doing a bit of basic life support, and then that went on to my interest doing some teaching when I was trying to learn on the medical rounds. I think that lots of people get involved in education that way, so I started with quite simple start.
In terms of your career, things have changed a lot. So back in the days where people were doing medical education, teaching, there was a lot of books people were using. Now things have changed. So tell us, what are you seeing?
Yeah, I mean, there is a lot of change. I mean, when I was at university, I used to sit with a little device called a Palm Pilot, which I don't know if you've ever heard of it. It was a long time ago. It was a really basic device where you could write on it, and I put all my notes in electronically, and that gave me a good start, a good base. And I've been wondering if there's been more and more useful ways to use data, because I still have those notes now electronically stored that I can refer to. So that's one of the advantages, isn't it, of having data stored in electronic format, is that you can manipulate it and use it in a way that paper notes, they would have been lost. I wouldn't still be able to benefit from them, and I wouldn't be able to adapt and grow them. So I like the idea of the flexibility of technology to help grow with me over time. And I was doing everything from a textbook then. I didn't have any aids to support me, any AI aids to support me or flashcards. So it was highlighters and very manual techniques. So it's changed quite a lot, I think, from then till now.
Nowadays, there is a lot of innovation with AI in the space of medical education, helping GP trainees. So tell us a little bit about your own experience.
Yeah, so in terms of use of AI, I think there are great potential benefits from AI in order to be able to rapidly access useful information. But there's also the potential for harms into learning. If you take shortcuts that you don't learn how to do it yourself, and if that AI crutch is taken away and then you're put in an environment like as an examination where you have to do it for yourself, if you haven't learnt the skills to do that for yourself, you're likely to come a cropper. So I think that is a potential risk. And particularly when it comes to things like reflection, it's quite possible to take a case, run the transcript of the case through an AI, and then ask it to write a reflection for you. But the point of writing a reflection is to learn from that case. So you're skipping out the learning. So there isn't a shortcut to doing that cognitive processing. You need to put your brain through that cognitive load so that you develop those nerve pathways, so that when you have to do it in real life, you've got them there. And if you haven't developed those, then that's a problem.
If, for example, you've got a GP trainee who's learning consultation from scratch, what would be the first things you would advise that trainee to do?
So I think I would advise them to think first and use AI second. So I would say that AI is a great tool and it can be really helpful. And I think one of the good things about AI is this zone of proximal development, Vygotsky's zone of proximal development, finding out where you are and then stretching you a little bit further. But before you resort to AI, first you need to try and think for yourself, what could the differential diagnosis be in this situation? Then check if AI agrees with you. And then the third thing you need to do is to check that the information the AI is giving you is true, because sometimes AI can make things up. And once you've found out if it's true, then I think you can knit that knowledge into your practice. So I use a little mnemonic TIck. So TIck stands for think first, then investigate with AI, then C is to check the information the AI is giving you back is true. It hasn't just got it from some blog somewhere. And the final is K, knit the knowledge into practice. So yeah, TIck is quite a useful little acronym to use for yourself if you're going to use AI. And I think you should use AI to learn, because it can be really great for helping you to think about differential diagnosis, to think about how could I have said this in a clearer format, more concisely.
What you're saying is for somebody to develop their own critical thinking and able to do it without the AI first, then possibly use the AI and check whether it's giving them good information that's accurate, then they can use it, rather than sometimes people might rely on it too much before they have set the right foundation.
Absolutely. I find that people are tending to just go to the AI first and then to do their thinking afterwards. But it's that cognitive effort of trying to work out what a differential diagnosis is that's really important for embedding the learning.
Your own interest in technology, where did it start?
Started at a young age. We used to have one of the first types of computers out was a computer made by BBC. The BBC used to actually make computers. And yes, and we could do exciting things like change the color of the font or get it to write a few sentences. And then as it got a bit more developed, we used to be able to play games on it, and we used to be able to break into the games and give ourselves more lives and things like that. So I was interested at an early age. And then as I went to university and technology developed, I got interested in using it to make my life easier in terms of when I worked in different places, I would use it to try and automate some of the tasks. So when I was working in the liver unit, we got it to automate all of the blood ordering system to make things easier for ourselves, and perhaps a bit more efficient and more uniform and standardized.
So then, have you developed skills such as coding? Have you developed other skills as well with computer?
Yeah, so I started off using the EMIS system, and I got very interested in what you could do with that because it's got lots of customizability within it. So it allows you to build workflows and concepts and logic blocks. So I really enjoyed doing a lot of that. And then EMIS looked around and saw who was using this system a lot, and they came and spoke to me. And then I got to work, they invited me into EMIS to do some work because I was doing a lot with them. And I developed that kind of clinical level of design and informatics with EMIS. And then in terms of coding, yes, my coding is I would say quite limited. I've written a few programs with coding, but I'm not I'm not a high-level coder. And I've been working with a colleague of mine, Peter Salmon, who is a fantastic coder and actually qualified as a GP, but then realized general practice wasn't for him, and has written programs in primary care and in secondary care, and also done some security work in banking. He's fantastic person, really brilliant mind.
So not so long ago, I was speaking with Prof. Anwar Khan, who mentioned about this CliniTalk app that helps somebody to analyze a consultation. So I understand that you were the one who started this. Tell us about the story of starting CliniTalk.
Yeah, so I was teaching on the RCGP it's the CSA course at the time with Roger Neighbour, Robin Simpson, and I wondered if there was a way that we could actually measure improvement quantitatively rather than purely through getting an examiner to look at it. So could we measure whether someone was sharing the consultation more? So we started off with simple metrics like how much time is the person speaking compared to the patient speaking in the consultation. And then we started to look at more complex metrics such as when do they start the management? How long do they spend allowing the patient to tell the story of the consultation? And that really just grew and grew. And then I got involved with Prof. Anwar Khan, Nicola Turner, Pete Salmon, and we started before AI really came about, before those GPT, generative pre-trained transformer architecture was even out there. But then we quickly realized that we could use this to give better and better analysis of the consultation. And the aim was really to help trainers and resident doctors to have a way of being able to get more feedback in between the limited amount of time they had access to their trainer.
When you analyze this consultation, can you share with us what are the common pattern of behaviors you have observed?
Yeah, I mean, we do see a very interesting pattern. I mean, when people start, one of the great things we've got is trending data. It's not possible for your trainer to be in the consultation with you all the time. And we've looked now across 13,000 consultations, and we find that when people start to consult earlier in their journey, you see things like they talk a lot more. You know, the doctor talk time is a lot more than the patient talk time. And as they practice and get feedback from their trainer and become more experienced in consulting, you see that doctor talk time coming down, and particularly in the more effective candidates that pass their consultation. So that's a really interesting trend that we see. And we also see the time at which doctors start their clinical management becoming earlier in the consultation too, which is really important for your SCA, because 43% of your marks are in clinical management. And if you start it late, you just don't have enough time to get those marks in the exam.
Absolutely. And that's where people rush, and also sometimes the management is not adequate. So many trainees have been using ChatGPT and AI tool for their revision. What do you think are the good use of tools such as ChatGPT and AI to help, and what are the things to be careful about?
So when you put your questions into a tool like ChatGPT, the answers are as good as the machine understands the problem. And that depends on its understanding of the context. So if you say to a machine, you know, how should I manage a patient with diabetes, your answer will be of a certain quality. If you say, how should I manage a patient of diabetes as a general practitioner, you're now telling, okay, you're not a specialist, you're a GP. So I understand now that you're a GP. So this is the context in which you're managing it. And then, is this a child? Is this an adult? So if you tell it, well, it's an adult, now it understands, okay, I've got to give you guidance. So there are many parameters that a machine needs to understand to be able to give you a useful answer that a trainer would already have the context to. So when you ask your trainer, how should I manage this patient with diabetes? They already understand, okay, this is an adult with diabetes. This is a UK general practice. I'm managing them to the NICE guidance. And so the risk is when you ask ChatGPT, not that the machine is inadequate necessarily, but if you don't have enough context information, you won't get such a good quality answer out. And that's why in the work that we do put a lot of effort into helping the machine and the AI understand the context and the scenario of the case that you're in, so that it can give you relevant information out.
Training the AI is one of the most important aspects into whether it's going to yield a really high quality output. And if a trainer is listening to this and they're thinking, if they're using AI to help with the tutorials, what do you think trainers can do to actually use AI and help their trainees?
So I think, yeah, if you want to use AI to write a tutorial, what I'd really advise you to do is to try to write a prompt or create a little an assistant that you can use again and again so that you don't have to do the work many times. So if you can create a little script that explains to it, I'm in UK general practice, I want to follow RCGP guidance and I want to follow NICE guidance. My trainees that I'm teaching are at the beginning of their training, or my trainees are almost ready to enter general practice, so that it understands the level at which to pitch it at. And then you can use those same standard instructions and copy and simply paste them into your ChatGPT every time you want to do it. Or you can create something called an assistant where it's got all that information stored in its instructions, and you can then just ask it questions.
There's different LLM out there. So in your own experience, as in what have you found that ChatGPT is quite good at? And then what are the other things that other LLMs might be better at?
Yeah, there's a lot of different large language models out there. And it's not as simple as saying what's ChatGPT good at and what's Claude good at, because within those different large language model systems, there are lots of different models within there. So ChatGPT is powered by a company called OpenAI, and OpenAI have lots of different models, and they're given them different numbers. And actually, even the way you write instructions to get the best output differs from one model to another. So to give you an example, in model 4.1 in OpenAI, you really had to give it quite step-by-step instructions, tell it how to think systematically, tell it with examples, many examples, to get the really best output. But in the latest models, actually being too rigid in your instructions, with 5.4 is the latest kind of model that's out there at the moment, that actually can harm the performance and constrain it too much. So there is some nuance and complexity. But I think that if you are just looking for an everyday model that will help you get good quality thinking out there, then OpenAI's 5.4 model is a good one to start with. It's not too expensive. It gives you good quality responses fairly quickly. And then Claude is very good. We use Claude a lot. You can look that up. Anybody can get on and have a look at Claude. I haven't used Grok. Grok is Elon Musk's slightly dodgy large language model, a bit controversial, should I say. And then there's some great models that are used to look at evidence. So there's one called Open Evidence. It's an American publication. It does really good summaries of the literature. And I really like that one too.
There's quite a lot out there and things change constantly in that space. So in terms of the GP of the future, then let's say if you can think about 5 years from now, how do you think are doctors going to teach and learn about consultation?
Yeah, so I think that it will be an evolution, not a revolution. And I think that AI is already there. People are already using it. I hope that it will enable us to have more of a data-driven approach to learning. By that, I mean that we will be able to understand more about how we consult because we'll have more data about how we consult. And there's the opportunity then with the data to find out what is effective in the way that we learn and the way that we teach. So that's one of the exciting things about what we're doing. So you imagine if we're both giving a tutorial and I give one tutorial on shared consulting and Erwin, you give another tutorial on consulting, and then we both monitor our trainees to see what their shared consulting is like using Cleaner Talk, for example, and then we can actually measure how much time they're speaking and giving to the patient, how much time they're sharing in the management, and see which was more effective, and then choose the most effective teaching styles based on real measurement of behavioural change. And I think that's what excites me, really, using the data to be really evidence-driven. I hope that will open up paths to improving learning and helping people who struggle, particularly those disadvantaged, perhaps statistically more disadvantaged groups, hoping to bring them up and support them better.
What do you think about the trainer-trainee relationship as well in that evolution? As in, back when GP registrars were trained, there was a closer relationship with the trainer. Nowadays, it's very busy. And trainers themselves are quite busy. And some trainees are not getting enough feedback, and some are using AI and other different tools that you've mentioned as well. So tell us, what do you think? Would that be something that will be less strong, or do you think that would be stronger?
I think the trainer-trainee or resident doctor relationship is really important because training is hard. It's a busy time of life. Often people have young families or other things going on, and medicine has become increasingly complex. So I think it's hard work being a GP resident doctor at the moment. So I really think you need a good, strong bond, and I don't think a computer is going to provide that to you. So I think the trainer role is absolutely central. I think that what it can do, though, is be a good partner for you, a good assistant for you to back up the messages that your trainer is giving you about your consultation, to help you understand those messages by giving the information in a visual context, not just in a conversation, letting you see the pattern and structure of your consultations, and also to help you in the time that you have with your trainers to make that time even more valuable by helping the trainer to see the areas of difficulty so that you can focus on them more readily, so that you're spending more of that, really high quality time talking about the issues that will make a difference for you as a trainee in developing.
Yeah, so that sounds quite good. Can you give us some context, as in for trainers who've been using Clinitalk, what have they said?
Yeah, I mean, we've got some trainers that have given their feedback, and we've sought feedback from trainers as well. So there's some information on our website, some videos of trainers talking about their experience. I think one of the comments that they say is that they're impressed about the quality of the information that it brings back. That one trainee we've got on there, saying Marta, saying, well, I showed it to my trainer and she looked at my feedback and she said, well, that's what I would have said about your consultation too. But of course, it is not perfect. It doesn't pick up all of the nuances. It's not possible because some of the information is not visible to it when you record a consultation. It doesn't have access to your medical notes, so it doesn't know some of the background that you would have known as a doctor. And it doesn't have the experience of knowing that patient as a person that the trainer might do. And so I think that it will get you along the way. It will help you to learn about areas of management that you perhaps hadn't considered. I find a particularly good one, the self-care and self-help strategies. I think often people are less familiar about suggesting self-care and self-help strategies when they're in a consultation scenario, and perhaps that sometimes gets forgotten because people are concentrating on the pharmacological side of management. So I find that's quite helpful in terms of giving you more of a broader view. So I think that it really can help to back up the trainer. It can help you to revise, and it can help you to learn areas that you might not thought of if you hadn't had that extra support.
That's great. Yeah. So it gives you new insights and also suggestions, as in what you might not be thinking about the consultation.
Yeah, we break the feedback down into 9 areas which are mapped to the SCA. So largely they're broken down into data gathering, clinical management, and relating to others. And it's looking at, listening to the story that you've got. Was the diagnosis that you gave, does that match the kind of pattern that came across? And Was your language clear? Did you share the management? Did you take the patient's ideas, concerns, and expectations? And then did you tailor your management, taking into account their preferences? So it's looking at all this kind of area and trying to give you comments about whether it's likely you did that behavior, that's a positive behavior, that's a behavior that's associated with high performing candidates, or was there an inconsistency? That behavior didn't seem to be present. And what it's really trying to do is just to say, hey, look at this area of your consultation. This is an area you might want to think about. We're not telling you you did it right. We're not telling you you did it wrong. We're just saying this doesn't seem to quite align with what the Royal College of GP guidelines are or what NICE guidance are. Why don't you reflect on this area? It might be somewhere you can learn.
So it's more like food for the trainee, the resident doctor to think about what they've done and then start the reflecting process.
Yeah, and we try to do that with a traffic light system to make it easy for people to identify areas of the consultation that might need a bit more focus, and try to give little light bulbs with key bits of information next to it so that when you're busy in your consultation, you can just take in these snippets of information, and we do a top 3 learning points from that consultation. But if you've got more time, you can click on a button called Deep Dive, and it will give you a lot more detail about why it came to that conclusion so that you can discuss it or think about it with your trainer, or if you're on your own and need to do some work.
Tell us about your vision then. Like, where do you see Clinical going and what are you working on towards?
Yeah, so the vision is really to be an assistant to resident doctors so that they be recording consultations regularly in the system so that they can, early in their training, learn good behaviors rather than starting off in training, having most of their consultations unobserved, which is what happens now because it's not possible to observe everyone's consulting. You have a chat after your consultation, perhaps, to say how it went, but nobody's actually observing you in the consultation. And to allow that observation to occur early on so that it helps you to develop good behaviors rather than you develop perhaps some bad traits, which you then try and unpick later. And the aim then being that because you've learned the good behaviors earlier, you become more fluent and you pass your exams first time. So there's less extension. So it's less stressful for you, less costly for NHS. And we get a good flow of doctors through the system.
It's really important for resident doctors to learn consultation skills early. And you've explained very well as in what are the pitfalls to avoid and how to use AI, and for trainers as well, how to be more efficient in the way of helping the trainees. So any last piece of advice for somebody who might right now feel that they don't really know what they're doing wrong and feel like they've sat the exam multiple times, they're struggling?
So if you sat your exam a couple of times and you're not really sure why you're failing the exam, I think the first thing to do is to look at the feedback that the examiners give you, the feedback grid. And I would do that with someone who's experienced, like your trainer or your training program director. Try and identify what are the main areas for you. I know that for some, it can be exam nerves, and in which case it's really important that you become fluent and you do in your everyday practice what you do in your exam, so that when you're under pressure, you don't revert back to bad behaviors. So some people I know learn some kind of approach for the exam, but they don't do that in their everyday, and that can be a problem. For other people, it can be a language or communication problem. It's more likely to be the case of it being a language or communication problem if you're someone who hasn't grown up in UK culture, because you're having to learn not just the exam technique, you're having to understand a culture that you haven't grown up with. And so I know that language can be an important barrier, because if you don't get the cues and the signals for people because it's not your natural or first language, that does make things harder, in which case really working hard on your language has been important. So I've had certainly had some train resident doctors from international medical graduates where language has been a problem, and it's really difficult because people have wanted to help and they haven't wanted to offend the person, so they haven't told them that they have difficulty understanding what they're saying. And it's because they're too nice in a way, they don't want to offend them. They're not prepared to say, well, actually, I find it really difficult to understand at times what you're saying because your phrasing is difficult or you've got quite a strong accent. But I think it's really important for people to be able to be honest, to do it kindly. I really, really want to help you, but we've got to address your language and improve on this because if I find it difficult and I'm trying really hard, it's going to be difficult for patients too. And that has made a big difference actually when people that I've taught or been involved with, when people have been able to have those conversations. Is that something you've experienced?
Absolutely. I think language plays a big part of it, and also sometimes the GP trainees who've been qualified overseas, they have been trained a very different type of consulting, so they feel that they're being professional if they are not showing this emotion, and then that way they might not appear warm in the consultation. But actually, that's something that needs to be first understood before they can apply it.
Yes, absolutely. I mean, I think there's a phrase that I like, is that people don't care what you think until they know that you care, and that expression of emotional understanding is important in UK general practice. And I have a mnemonic that I teach to my trainees, which is KISS, which is kind, interested, safe, and see the big picture. So I think that to be a good and effective doctor, you have to show that you're kind, that you're really interested in your patient, that you are practicing safely in line with national guidance, and that you see the big picture of what's going on in that patient's life, what's going on in how the disease is affecting them or how the condition's affecting them, how it's affecting their family or their work life. If you can get to the end of a consultation and say, I was kind, I showed that I was interested, I was safe, and I can see the big picture of what's going on, I think there's a really good chance you'll do well in that consultation.
That's great. Yeah, that's about being a good GP. So you're really caring and showing that compassion. And I think in an age where technology is progressing rapidly, we have seen that there are many people who are feeling more lonely, and that human skill is going to be more valuable. I don't know how you felt about it, but this is something I'm seeing at the moment where more and more people are feeling a little bit disconnected, even though we're connected with the whole world. But that human connection and communication is going to get more important.
Yeah, absolutely. I mean, when people are upset, being able to put a hand on their hand and feel that that person's there, it's difficult to quantify how important that is to people, even when perhaps they're medically towards the end of the road and there's not a great deal that you can do for them from a medical standpoint. Being able to share that experience with them and to show them they're not alone, I think it is really important and is very valued. And it's not something a computer can do.
Absolutely, yeah. So it's been really great to have a chat with you today, Nick. And I see that there's a lot of value in what you're doing and helping GB trainees and trainers as well to not just help them with a consultation, but also helping them save time as well in their work. And I wish you all the best in what you're doing.
Thank you, Erwin, and it's been great to talk to you. And I can see your consultation blueprint book in the background. I understand that's going well, so well done for that.
If you found this video useful, then you'd love the next video with Roger Neighbor, where you'll have a deep dive into the consultation and how to score well in the SCA. Click here and I'll see you on the other side.